to invite Dr. Maen Abdelrahim up to the stage. He's a professor of medicine and the chief of gastrointestinal medical oncology, as well as the director of the Cockrell Cancer Center for Advanced Therapeutics at Houston Methodist Neal Cancer Center across the street in the Weill Cornell Medical College. He's here to kind of talk about the prognostic, or using MRD as a prognostic tool and the prognostic implications of this technology for our colorectal cancer patients. Thank you so much. Thank you so much.
Of course. Okay. Good afternoon, everyone. Nice. Awesome. Okay, thank you, Dr. Morris, for getting us all together here. And this important topic is about the time, actually. We've been hearing a lot of data since morning about the utility of ctDNA, MRD. And I think you had a lot of clinical trials, prospective, retrospective. And I think I would start by putting it together with a prospective or representative case for a patient, and pay attention to the details of the timing of the diagnosis till now. And then I'm going to switch to talk about MRD, what it means to us as a GI oncologist, and why it matters in real life practice. Then we talk about the prognostic biomarkers and the ctDNA guided strategy, risk stratification tool for adjuvant therapy, and ctDNA as a dynamic biomarker in metastatic setting, even though we are focusing on MRD, but I'm going to talk about and present a few slides about metastatic setting, because once you have MRD positive, you start treating it as metastatic disease in the setting. So this patient, 64 years old, came in with SPO, anemia. CT scan showed cecal mass, partial SPO, and ileocecal lymph node positivity. Colonoscopy has been done, biopsy was acquired, and the diagnosis is invasive adenocarcinoma. Nothing exciting about molecular testing here, G12D in NRAS. So you have a surgery 3 weeks after diagnosis, right hemicolectomy, and end up with a final stage of T4N1 with stage 3C. CEA is normal all the time. So after surgery, we had post-surgical scan, and it showed no evidence of disease. However, ctDNA was positive for this patient, and that increased his anxiety and our anxiety, because we know it's a problematic for this patient. So we treated him with 6 months of FOLFOX. That's a clear ctDNA from the blood, and CT scan continued to show no evidence of disease, but in less than a year, ctDNA positivity came back. And at that moment, there is a CT scan showed some retroperitoneal deposit. We put him on FOLFIRI Avastin, and that's a clear ctDNA again. And CT scan showed partial response, so we de-escalate the treatment to a maintenance therapy with 5-FU and BEV. And later on, his CT scan showed stable disease, but ctDNA showed otherwise. ctDNA continued to rise, and we decided to escalate up his treatment to FOLFIRI BEV, and the CT scan continued to show stable disease, even though ctDNA continued to rise up. At that moment, he was referred to surgery team, and they did EPIC surgery. EPIC mean early post-surgical intraperitoneal chemotherapy. It is the fancy name for HIPIC, basically. So patient got ctDNA clearance again, and CT scan showed no evidence of disease. Was like on and off, but there's below the detection level. But later on, ctDNA continued to rise, and CT scan showed bladder deposit. And ctDNA continued to rise. And remember, this patient is diagnosed in 2020, and we are 2023 now. So ctDNA continued to rise, and then we had an ablative radiation therapy, and that was cleared, actually, his ctDNA from the blood. So he have clearance, and ctDNA or CT scan continue to show no evidence of disease. Some scars. I don't know what the scars mean, but turn out with the ctDNA going up, these scars actually is soft tissue and para-anastomotic area, and ctDNA continue to rise up. And now we are in 2024, and we started 2020. Then that rise end up of referral to surgery and resected, and that put him back onto ctDNA clearance again, and that was done with multiple CT scan and showed no evidence of disease, but post-surgical changes, quote unquote. Then ctDNA go up again and continue to rise, and at that moment we give him again the same chemotherapy because it's been more than a year now, and he have some response, clearance, and then been fluctuating in his ctDNA, and the CT scan later on, some report showed soft tissue nodulity in her bladder, in her bladders, and ctDNA continued to rise up, and at that moment we refer to surgery again and have cystectomy, partial cystectomy, and now we are in 2026. A few weeks ago, he have a ctDNA negative. So this patient started in 2020, and now we are in 2026. This is a patient's journey where we have a ctDNA basically guided treatment. Some of the CT scan was misleading, but the ambiguity of a CT scan can be cleared by a good test. Okay, with that in mind, what it means to us is when you have MRD positive, that is, you have micromets before you see it in scan, and ctDNA positivity become the PSA of the CRC. So biochemical recurrence on a prostate cancer is going to be treated. So the ctDNA in colorectal cancer is going to be treated as well. Sometimes we didn't treat the numbers, we treat the scan, but I think you saw it. The ctDNA can reflect a disease, and that might give you some guidance. Why it matters? Because we know, Dr. Morris mentioned in his presentation that 30% of early CRC can have a recurrence, and the traditional histopathological or clinical pathological biomarkers, lymphovascular invasion, berineural invasion, T4, all this is good, but the hazard ratio is low. All of them, like, not worth of a 3 to 4 ctDNA positivity with a higher hazard ratio. MRD offer real-time tumor-specific biomarkers, so MRD positivity mean biological evidence of impending relapse, and that actually shift the CRC management from population-based to personalized risk assessment. And the case I present is a good example of that. You don't have to follow the guideline, it's case by case. So ctDNA reflected tumor-specific genomic alteration, short half-life, mentioned earlier, enable dynamic disease monitoring, and detect relapse months before radiographical progression, which is the lead time. And MRD positivity, by now, it is a bad news, poor outcome, increased risk of recurrence, and it outperform CA, standardized clinical pathological risk. So it means currently it is the strongest prognostic biomarker in resected CRC. I want to spend a couple of slides on Galaxy. Dr. Morris mentioned this earlier, but from my perspective, this is the largest prospective MRD data set and multinational study. They look at stage 1 to 4 and the serial ctDNA monitoring. They look at MRD window as well as the surveillance window. What I try to highlight here, the 24 months disease-free survival was 85 to 90% for ctDNA negative, and it's only 28 to 33% is ctDNA positive. Hazard ratio is 11 for BFS, and for OS, it's 9. So take-home message, ctDNA is the strongest independent prognostic factor in this setting. Positivity with inferior OS for patient with radiological recurrence, and as you can see, the hazard ratio is 2.7. Does it matter where it come from or the metastatic site? No, really. Predictive of OS across all recurrent site post-surgery, from lymph node, peritoneum, lung, liver. Hazard ratio is 2.5 in average, but sometimes in real life, you're going to see differences of shedding of ctDNA from peritoneum compared to other site. So clearance of ctDNA, that means improve outcome, and this is, as you can see, in 3 months, the hazard ratio is 5, and 6 months, the hazard ratio is 11, and this is highlighted earlier. So the clearance of ctDNA is another thing we looked at. And also, the persistence of MRD or ctDNA is a bad news. And Dr. Morris mentioned this earlier. As you can see, when there's no clearance, is a bad news, but it's better than a transient clearance, and sustained clearance is the best outcome. What take-home message from this is that prognosis is actually dependent on kinetic of ctDNA is not one test. So in real practice, we don't make judgment based on one ctDNA test, but rather than a couple of those will help you to make a decision. So establish MRD as a powerful prognostic and disease monitoring tool. The dynamic trials can actually answer the question, can ctDNA guide approach reduce the risk or use of adjuvant chemotherapy without compromising the recurrence of risk? So what you can see here in short is that stage 2 colorectal cancer patient who have a resection was randomized to standard of care or to ctDNA informed decision. So for the standard of care, for those who have a low risk based on histopathological or clinical indication, have no or receive no adjuvant treatment. Those with high risk features receive an adjuvant treatment. And the other group with the ctDNA informed group, those with positive ctDNA was treated with adjuvant and those with negative was not treated. This is the most updated data from this trial. As you can see, in the standard of care group, 28% receive adjuvant compared to 15% in the ctDNA informed group. That means there's a 50% reduction of using adjuvant chemotherapy. And we're talking about toxicity to the patient. So half of the patient, you save them from chemotherapy. The outcome was not different. The 5-year survival and the 5-year overall survival was not compromised. So not giving adjuvant therapy is actually does not compromise your patient outcome, but you save them. And we know oxaliplatin can have complication of neuropathy and quality of life. So 50 of the patient, you can save them from toxicity if you did a ctDNA test and you're able to make the right clinical judgment. So ctDNA guided strategy decrease chemotherapy use without compromising an outcome. In the other end, the COBRA trial, similar design, but I want to highlight 2 things here. In the COBRA trials, the low-risk patient, T3 and 10 mainly, and they divide them to standard of care compared to assay-directed therapy. The assay here is plasma-only ctDNA, which is a tumor uninformed, and they treat the patient based on the ctDNA positivity or negativity. The outcome is highlighted here, or actually the objective is highlighted here. Basically, they looked at clearance of ctDNA, RFS, OS, and feasibility of ctDNA guided strategy. The result, they stopped early for futility, and they conclude that there is no improvement in ctDNA clearance strategy and no demonstration of a clinical benefit of ctDNA guided approach. What happened here is that, the take-home message, the ctDNA guided strategy not supported in a low-risk stage, T3, 0, and 0, need for a tumor-informed assay, and better patient selection, the higher risk patient likely to benefit more on those patients. When you put it together, dynamic and COBRA trials, the bottom line for this is that, ctDNA works when the right patient, basically those with higher risk, and the right assay, the more sensitive one, and maybe the tissue-informed are used. So this is the last question we try to answer. Can ctDNA guide approach predict treatment, response, and outcome? I chose this trial because this just published a couple of weeks ago, and it is actually the largest systemic review and meta-analysis. They have 64 studies included, more than 2,700 patients. And the key concept here is ctDNA kinetic, early drop or rise, reflect real-time tumor biology. I'm not going to detail this, maybe 10 tables like this in the study, but I present this here to show you the heterogeneity between tumor-informed and tumor-uninformed, the line of treatment when they use ctDNA. So it's a big study, and I think it's represent what we've been discussing in the morning. And they find out that the unfavorable ctDNA kinetic were associated with a shorter OS, pooled HR of 2.6. It also have association with a shorter PFS with pooled HR hazard ratio of 2.7. They did a subgroup meta-analysis of comparable ctDNA cutoff. Basically, they look at increase or decrease, and they conclude that increased ctDNA is associated with a shorter OS and BFS with hazard ratio is 2.8 to 3. They also look at the ctDNA clearance, and we know this is importance, and they found that the lack of clearance associated with a worse OS and BFS with a pooled hazard ratio is 2.5 in average. So why this study mattered? Because it's the largest and the most comprehensive analysis of ctDNA as a dynamic biomarker for metastatic colorectal cancer. What's we benefit from this. What the clinical implication? Basically, it's identify a responder within weeks of therapy. It's track a tumor burden continuously. It's a dynamic test. And it detect resistance before radiological progression. And when they compare it to images, it's provide an earlier detection. And when we compare it to CAA, to provide you with higher sensitivity and specificity. We do treat colorectal cancer differently nowadays. Stage 4 colorectal cancer with liver-only disease that is unresectable can be cured. How can you cure that? By transplant. So you can offer transplantation for patients with stage 4 liver-only without an extrahepatic disease. And this is an evolving field in transplant oncology. So if ctDNA has been helping you to do a simple surgery, colorectal surgery, this will be more beneficial when you do a major surgery like a transplantation. It takes $1 million to transplant a patient, and it takes 9 months to 12 months to make an orthotopic liver transplantation for a selected patient. So this has become an important tool to select patient before transplantation when you look at the new adjuvant response. And also, I don't think you want to transplant a patient with ctDNA going up before transplantation, even though a CT scan showing that stability of a disease. That means it is the biology is not the right, and maybe there's a disease progression, but to be captured later on. Once you do transplantation, the patient be on ton of immunosuppressant, so the immune surveillance for cancer will go down, and so you have to have a clear selection. So ctDNA in this setting will help you to decide and select patient for transplantation. In addition, there's no clear guideline what to do after transplantation. Do you give those patients an adjuvant therapy, even though they are an immunosuppressant and they've been through a major surgery? That's also going to help us to make a decision. This and other concept is actually published on our transplant oncology book last year or the year before. And we talk about ctDNA for 3 chapters on this book, not only transplantation, but also others. With that, I would like to thank our team who participate on these studies. We have actually a study I've been asked not to present because there's intellectual property to it, is using cancer vaccine, mRNA vaccine, actually after ctDNA positivity for CRC. So we develop an mRNA core at Methodist, a vaccine specific for the patient. And that is actually a trial where ctDNA is going to be guide to select patient to give them a vaccine. So hopefully next year, if Dr. Morris invite me again, I will present some of this data. With that, thank you for your attention.
Yeah, thank you so much. This was a fantastic talk. We will always jump at the opportunity to invite you to come over. So we look forward to hear what you do and your group does in the coming years with the mRNA vaccine. We're very excited about that. One quick question for you. How, in the de-escalation approach, do you find that patients are, willing to incorporate the ctDNA discussion into stage 2 disease if you're kind of on the fence going in about adjuvant chemotherapy?
Yeah, that's a good question. And I think the patient are split when we start talking about, can we add this to your treatment planning? Some patients, they don't want to know. If a CT scan is negative, and they don't want to increase their anxiety about ctDNA. And actually, we try to, like 6-7 years ago, we said, okay, well, this is validation. There's more data coming up. But now we try to educate our patient and tell them, okay, well, this is going to help you. We don't have to make a decision based on one ctDNA test. But, if in doubt, we can repeat it in a short period of time. And if the slope is going that direction, there is this ctDNA coming from a cancer. This is the way I describe it to them, that there's cancer somewhere that sheds ctDNA in the blood circulation. That's why we're able to detect it. And when it's going that direction, that means it is growing. So sometimes, do we offer a treatment based without a clinical trial, without, just basically clinical practice? We have a discussion. And if there's patient that is high risk for recurrence, we take in consideration not only ctDNA, also the clinical. For example, this patient have a T4. So when we talk about, they said, okay, well, T4 is worse than actually stage 3 with N-positive disease that is likely to less recur than T3. So in this case, it was not a no-brainer to him to give him a chemotherapy. So I think it's a discussion, but now I think we have more evidence to offer based, as we said, like a PSA of the CRC.
Okay.
Okay, sure.
Thank you so much. It's really next privilege to get to invite Dr. Nancy